Okay, Bismillah ar-Rahman ar-Rahim. Today we are going to have a brief about the vascular curriculum for you. To start with, vascular surgery is divided into arterial part, venous part, and lymphatic. Simply speaking, the arterial part is about occlusion or dilatation of the blood vessel. Occlusion of the blood vessel could be acute or chronic, which is called ischemia. We have an acute ischemia and a chronic one. Also, there is some form of increase in the caliber of the blood vessel, which is called the aneurysm dilatation or dilatation of the vessel. Both conditions, either to have a stenosis or occlusion of the vessel or have dilatation, have a negative impact on general health of the patient. On the other hand, venous system or venous problem in the patient also is about occlusion or dilatation. When the venous system is occluded, the occlusion is called thrombosis, and thrombosis could affect the deep system, so it is called deep venous thrombosis, or superficial system, which is called superficial thrombophlebitis. Dilatation of the blood vessels called varicose vein, or could be a secondary varicose vein, or what is called apoptophlebitic syndrome. And lastly, lymphatic system affection, which affect lymphatic system. There is some combination between both. The arterial and venous could be communicated in abnormal communication, resulting in arteriovenous fistula. That could be traumatic, that could be congenital, whatever the cause. To start with the venous system, and to know, today we are going to discuss venous system and the aneurysm. We may meet in another session to complete the vascular curriculum, because to discuss these two topics in 2 hours is more than enough. We cannot do more than this. This is the simple anatomy of the venous system. The venous system is composed of two systems, a deep system and a superficial system. To differentiate between both systems, we differentiate by a fascia. The structure which is superficial to the fascia and nearer to the skin is called a superficial system. And superficial system include the great saphenous vein, small saphenous vein, and any communicators between them. The great saphenous, short saphenous could be communicated or connected together by a communicating veins. On the other hand, deeper to the deep fascia is another system of veins, which is called the deep system. Deep system is named after the accompanying arteries. That's to say, we have a popliteal vein, we have a femoral vein, we have a vena competent for anterior tibial, posterior tibial, or peroneal veins. Superficial system and deep system are communicating together. They are communicating through channels, which is called perforating veins. We call them so because they can connect each other. Just they have to perforate or penetrate the deep fascia to communicate between both systems. To speak about perforating veins, we have a lot of perforating veins. They are about 360 perforators in the lower limb, and they are classified into groups, which is called after the scientists that discovered them. We have cocket, dots, poids, and so on. This is another diagram showing the superficial venous system. The main veins of the superficial system is great saphenous vein and a short saphenous vein. Short saphenous vein is starting on the lateral aspect of the leg, and great saphenous vein is starting on the medial aspect of the leg above the medial malleolus. Both veins will end in the deep system. The superficial system responsible for a minute amount of drainage of the blood. They are responsible for draining about 10% of the veins of the venous return of the lower limb. The short saphenous end in the popliteal vein. Meanwhile, the long saphenous end in the femoral vein. I have to stress about these tributaries because we're gonna discuss these tributaries during treating varicose vein. Before the great saphenous joins the femoral vein, it receives some collaterals or tributaries which is important before doing the surgery. This will be discussed later. To have a sound hemodynamic system in the lower limb, we have to know that we have multiple valves. These valves control the flow of the blood. The flow of the blood is controlled to, or is directed to be from downward upward and not reverse. And this is because of presence of valves. The valve is present in the superficial system and in the deep system. We have another valves that prevent or that just allow the blood to flow in one direction from the superficial to deep system through the perforator. These are the perforators that communicate or connect the superficial system with the deep one. These perforators are guarded by valves that prevent the blood from going from deep to superficial. So to summarize, the blood is going from downward upward and from superficial to deep and not the reverse direction. If you have a reversal of blood flow, then your patient is suffering from what is called chronic venous insufficiency. And this is the venous system in the abdomen consists of both iliac veins, inferior vena cava, and meeting the superior vena cava to end in the heart. You have to note that there is no valve in the venous system in the abdomen. So the valves stop at the groin. After the groin, all the veins does not have any valves during their journey up to the heart. This is very important because it will explain some clinical finding for the patient. We're going to discuss venous insufficiency. What is venous insufficiency? Venous insufficiency, it means simply the vein is not capable of performing its proper function. What is proper function of the venous system? The proper function is to drain the lower limb and carry the blood back to the heart to continue its circulation. What is the causes of venous insufficiency? The causes could be an overflow obstruction. There is something that obstructs the vein, so the venous return during its journey is impeded by presence of obstruction. Obstruction could be stenosis in the wall of the vessel, compression from outside as a pregnant uterus, for example, or abdominal tumor. We may have some sort of valvular incompetence, as we have said. The valves prevent blood from reflux. That's to say, the blood is going downward, upward, and from superficial to deep system. If the valve is incompetent, then the blood will reflux, and so the venous system will be insufficient and will not function properly. Also, we may have an arteriovenous malformation. There is a communication between artery and vein due to different causes. This communication will cause an increased pressure in the venous system and hence the venous insufficiency of the patient, or we may have a combination of these three causes. To classify the problem of venous insufficiency, we said that this is the syndrome that we speak about, chronic venous insufficiency. What is chronic? It is a chronic condition, not an acute one, affecting the venous system, resulting in improper functioning of the venous system. When you have chronic venous insufficiency, it could affect the superficial system or could affect the deep system. So we have chronic venous insufficiency, either chronic superficial venous insufficiency or chronic deep venous insufficiency. For the patients that have a chronic superficial venous insufficiency, we have a primary chronic superficial venous insufficiency. This means that there is no prominent cause of disruption of the valve system. So the patient have a disruption of the valve system and have a reflux in the venous system without unknown cause. That's to say, it is not due to, for example, previous DVT. It is not due to presence of arteriovenous fistula. And this primary chronic superficial venous insufficiency is simply called primary varicose vein. The superficial system could be affected, but affected secondary to defect in the deep system. The deep system is affected by any problems that we have mentioned before. Could be valvular destruction due to previous DVT, could be due to tumor compressing the veins from outside, arteriovenous fistula, and this results in increased pressure in the deep system, and this increased pressure will be reflected on the superficial system, resulting in varicosities of the superficial system. So this is simply called secondary varicose vein. To summarize, when I mention primary varicose vein, it means that I have a problem in the superficial system only without a known cause. When I have a secondary varicose vein, this means that I have a problem in the superficial system, and the superficial system is not accused for this problem. The accused one is the deep system. So whenever I tell you what is primary varicose vein, you have to tell me that the deep system is okay and the problem is the superficial system. Whenever I tell you what is secondary varicose vein, you have to tell me that the deep system is bad, is affected, and this have an impact on the superficial system. Another form or another arm of the chronic venous insufficiency, what is called the chronic deep venous insufficiency. Chronic deep venous insufficiency, it means that the deep system is affected and there is a disruption of the hemodynamics of the deep system. You have to know that both arms are connected together. That to say, whenever you have a problem in the deep system, this means that you have a pressure inside the deep system which is higher than normal, so there is a venous insufficiency. This results in affection of the superficial system, and hence the patient will have a secondary varicose vein. So chronic deep venous insufficiency, either primary or secondary. Primary means there is no previous cause. We discover that the deep system is not functioning good without a proper cause. Or whenever we found deep system is affected due to previous DVT, this part could affect the superficial system, resulting in what is called secondary varicose vein. So I have a problem in the venous system, could affect superficial system, resulting in varicose vein, primary varicose vein, or I have a problem in the deep system, resulting in increased pressure of the deep system, and hence a secondary varicose vein of the patient. Varicose vein, if you have to classify varicose vein, we already have mentioned, two classifications: primary varicose vein and secondary. Primary is means that the deep system is intact, meanwhile secondary means the deep system is not good. But we have another classification according to the shape of the vessel. We could have some red telangiectasia, some dilated veins which is red in color and small in caliber. We may have what is called the blue telangiectasia, a larger and more condensed blood vessels, and violet telangiectasia. All these form, red, blue, and violet, are affecting the cutaneous veins, but with different severity, starting from red, blue, and violet. On the other hand, I may have tributaries of the major veins, which is superficial or deep, tributaries of saphenous of short saphenous, resulting in reticular varicose vein. Here, the affected part is not the main trunk, not the great or superficial vein, but the tributaries of the trunk. And this is truncal and truncal varicosities. The great saphenous is affected along the thigh and the leg. Don't expect to see this form of varicose vein in every patient you examine in the hospital, because it is a classical form and it is not always present. You may have these reticular veins or you may have truncal form. Also, we said truncal and accessory. This is truncal affecting the great saphenous, and this is accessory where the anterior accessory vein is affected. You see the patient great saphenous, the anatomy of the great saphenous is present here, and the great saphenous is normal, but the anterior accessory vein is dilated, as you see. It is not the great saphenous, but the anterior accessory vein due to effect in the valve here. We have other form of varicose vein. It could be recurrent varicose vein. When the patient has a surgery for varicose veins and varicose vein return, it is a recurrent varicose vein. We may have this form of varicose vein. This is telangiectasia that we have seen before, but with this telangiectasia, we have localized dilatation, which is called varicose burst. It's like burst. This is very dangerous because they could rupture. As you see, the wall of the vein is very thick, and the pressure inside these veins is high. So the vein, if the vein ruptures, the patient will bleed a lot. We have some genital or valvular varicosities in the scrotum or varicosities in the valves that affect, they may cause some sort of dyspareunia or bleeding during labor or vaginal discharge. And it is a rare one, which is a varicosis of the persistent sciatic vein. During embryogenesis, there is a sciatic vein, which is rudimentary, become rudimentary and replaced by a short saphenous vein. And if the sciatic vein remain abnormally, if abnormally persist, it may be affected by varicose vein and doing varicosities. So as you have seen, we have two classifications of varicose vein. We have first classification, which is about primary and secondary varicose vein. This depends on whether the deep system is affected or not. And then we have a morphological classification, which is red telangiectasia, blue, violet, reticular, and this is another classification. So it's going to be a confusing one. So what is called SEEP classification is invented to clarify the classification of the varicose vein. SEEP is stand for C stands for clinical finding, E for etiology, A for anatomy, and P for pathophysiology. Let's go one by one. SEEP classification, C start with clinical. So according to the classification, according to the clinical presentation of the patient, you have to you can classify your patient into C1, which has some telangiectatic vessels, as we have seen before. And if the patient has a larger varicose vein, which is about 3 millimeter, something like this, it is called C2. And when the patient has edema that is caused by varicose vein, he has C3, some pigmentation, this is C4, and lipodermatosclerosis. What is meant by lipodermatosclerosis? There is hardening of the skin and subcutaneous fat. It is called C4B. So C1 and C2 is dilated veins. Starting from C, this is C3. This is about complications or other clinical problems that the patient may suffer from other than morphological or cosmetic part. The patient may have an edema, pigmentation, or lipodermatosclerosis. And C5, the patient has a previous history of ulcer, which is healed. And C6, the patient already have an active ulcer. So whenever you see your patient, you have to say that my patient, according to SEEP classification, is C1 or 2 or 3 or 4 or 5 or 6. If you have a venous ulcer and you examine the patient and you are asked to asked about the diagnosis of your patient, you will say the patient have varicose vein, primary or secondary, affecting the blah blah blah, and the patient have an active ulcer, which means that the patient is C6. We have also another subdivision, which is called S or A. If the patient have any of them without any problem, no symptoms for the patient, no pain, no ache, the patient is asymptomatic. So we can say the patient is C3, but it is A category. This means that the patient is asymptomatic. This means that the patient is having edema of the lower limb, but this edema does not bother the patient. He doesn't have skin irritation, no heaviness, no night cramps, and so on. This satisfies the morphological appearance of the patient. So when you see small veins, he has C1 or C2, and he have edema, C3, affection of skin, C4, ulcer either active or healed, C5 or 6. This is satisfy the morphological classification. But if you want to know what is the etiology, why the patient has varicose vein, this is the beauty of SEEP classification, because we have an etiological, or E stands for the etiology of the varicose vein. If the patient has a congenital varicose vein, so it will have, according to his C classification, he has EC, which stands for congenital, or the patient may have primary varicose vein or secondary varicose vein. This is the primary and secondary varicose vein. We simply said the patient has primary or secondary varicose vein, but SEEP classification is identifying the patient very precisely. The etiological classification tells us whether it is primary or secondary, and the C part, which is C1 to 6, they represent the clinical presentation of the patient. Also, anatomical classification. If the patient have affection of superficial veins, it is an AS. If have a perforating vein, it's P, and D for deep vein. So whenever you see a patient, you have to say the patient, my patient is according to SEEP classification. He has C6. This means that I have an active ulcer. The etiology of this patient, it is a primary or secondary according to the tabulations that we will see in the further in the future slides, and according to the anatomy, the affected part is superficial or deep. And it goes without saying that if I have a primary varicose vein, it affects the superficial veins, and if I have a secondary varicose vein, it affects the deep system plus or minus superficial veins. And pathophysiology, it means why there is an affection. I have a primary varicose vein, very good. Why I have primary varicose vein? Because the superficial system is affected. Why the superficial system is affected? Because I have a reflux. I have a problem in the valve, so there is a reflux in the superficial system, increasing blood flow in the superficial system, resulting in dilatation and the clinical picture. I may have an obstruction. This obstruction could be from outside, as a gravid uterus or a tumor, or from inside due to previous DVT, which does not resolve completely. So I have an obstruction of the vein. So I may have a secondary varicose vein with affection of deep venous system, plus or minus superficial system due to obstruction. Or the patient may have both. The patient may have a DVT that results in partial obstruction of the vein in some areas and the destruction of the valve in the other areas, resulting in reflux. Or sometimes we don't have a clear pathology. You can do duplex, for example, for the patient. You find dilatation, but you ask the patient to cough or strain, and there is no reflux or obstruction. So we can say that there is no pathology for us. This is very important because in the exam, in the clinical exam, we have two forms of patient with venous problem. I have a patient with primary varicose vein, and I have another patient with secondary varicose vein. I can differentiate between both primary and secondary according to the history. The history of the patient, age is not very important, but we said that the primary varicose vein tended to be younger than those with secondary varicose veins. The secondary varicose vein, as we have said, is due to the patient has a varicose vein in the superficial system, secondary to a problem in the deep system, and this could be, or most of the cases, due to DVT. The patient with secondary varicose vein have an aggravating symptoms, pressure. As pressure in the deep system is much more raised than the primary varicose vein, and the complication is more with the secondary varicose vein. We have said that during sailing with the SEEP classification, the patient may have edema. What is the cause of edema? This diagram simplifies the cause of edema. I have an artery that gives blood to the organ. Then the blood will go to the capillary and then return through the vein. Sometimes we have an extra fluid that will go with the lymphatic flow to remove. So the blood will diffuse from capillaries, or the fluid that will diffuse from capillaries due to arterial blood pressure will be completely absorbed by the vein and by lymph flow. If I have a problem in the lymph flow, the patient will suffer from lymphedema, and if I have a problem in the venous system, which is venous insufficiency, the vein will not be capable of withdrawing the whole amount of fluid that is supposed to be withdrawn by the vein, so resulting in increase in the pressure in the capillaries, and hence increased fluid in the interstitial space and edema. And the first part to see edema is a pre-ankle area, because the skin here is smooth and lax. So whenever the patient have edema in this, it will appear obviously. And the edema in the venous system in most of the cases is pitting edema, and whenever you see edema in your patient, you have to comment on the edema You have to comment on whether it is soft or hard, beating or not, and you have to go upward part by part until you see the end of edema, and then you have to describe what you have seen. I have a soft edema, pitting edema affecting the lower limb until the level, for example, of the knee joint. The patient of varicose vein could suffers from ulcer or edema. So whenever I have edema of the lower limb, I have to know what is the differential diagnosis or what are the other conditions that cause edema. If I have bilateral edema, this means that I have some sort that caused systemic causes that affect both lower limb. As you know from the internal medicine, this could be due to heart failure, hepatic failure, renal failure, hypoproteinemia, allergy, and so on. On the other hand, I may, sorry. On the other hand, we may have localized edema. The localized edema most probably is due to vascular cause. This may be lymphedema that we have said before. This could be due to an arteriovenous fistula that increase pressure in the capillary side, and this could be due to chronic venous insufficiency or congenital vascular malformation. We have another important differential diagnosis for vascular patient, which is an ulcer. What is ulcer? Definition of ulcer is very important. It is diminution of epithelium. So diminution of epithelium could be due to arterial cause. When the patient is ischemic, you have some sort of destruction of the skin and hence the ulcer. The differentiation of ischemic ulcer is very simple. Simply, you can see the patient has what is called dusk red skin. Dusk red skin means that there is a dilatation of the cutaneous blood vessels due to presence of metabolites. And when you palpate pulses of the patient, you cannot feel pulse, and the patient give you a history of intermittent claudication. And as you say, the ulcer is painful. There is a necrotic necrotic part of the ulcer. On the other hand, venous insufficiency. You see the patient leg is swollen, there is lipodermatosclerosis, and the ulcer present, and we emphasize that the ulcer is in the gaiter area, which is a medial part of the lower limb, and we see why it's in the gaiter area. The ulcer also could result from it's something like ischemia, but ischemia on the capillary level, which is called vasculitis. Vasculitis is an autoimmune disease that affects the capillaries, resulting in inflammation, and hence inflammation of the blood vessel leads to occlusion of the capillaries, and hence the ulcer. And the treatment of this vasculitis or vasculopathy is by high doses of corticosteroid. We have lymphatic ulcers. Patients have lymphedema, edema, non-pitting, brownie. Brownie means it is hard, not soft, and sometimes there is an ulcer due to swollen limb. And then, and lastly, malignant ulcers that you have studied in the plastic surgery, which is basal cell, squamous cell carcinoma, or ulcerated melanoma. As we have said before, during SEEP classification, we said according to the etiology, we may have varicose vein, which is primary, secondary, or congenital. And this is a congenital varicose vein. You will see varicose vein in the patient, but the varicose vein is not due to what we have said before, not due to presence of obstruction, for example, or absence of valve or destruction of the valve, but due to abnormalities in the vein system. You may have no femoral vein, and it is replaced by superficial vein. How you can differentiate the patient has a congenital or congenital varicose vein or an acquired one? When you examine the patient, you will find what is called a port wine stain or large nevi or discoloration of the skin. You will see the patient, your patient is young, and you may see one of the lower limb are gigantic than the other ones. You may have some giantism of one lower limb compared to the other. The patient with congenital varicose vein is contraindicated for any surgery for varicose veins. There is no stripping, no radio frequency, and so on. اوكي، قلنا الدايجنوزس بتاع الفاريكوز فين. you have to have a thorough history examination of the patient to differentiate between primary and secondary varicose veins. The history entails that any cause that may result in previous DVT. We have to ask the patient about lung recumbency, presence of previous fracture, orthopedic surgery, previous history of a swollen limb that necessitates some bed rest, lytic elevation, and the previous anticoagulation. All of these increase the suspicious about having a previous DVT, and hence the varicose vein could be a second one due to affection of the deep system. Clinical examination. Whenever you have a case of varicose vein, you have to examine the patient and prescribe what you have seen. In this lady, for example, I can see the great saphenous vein is dilated from the groin down to the leg. In some cases, we only see the anterior tributary of the great saphenous. Sometimes we see some radicular veins. So it is not always the case. It is the classical case that you will not see in every case. On the other hand, we may palpate the lower limb to find some sort of defect in the fascia. Through this defect, the perforators could penetrate and dilate. I have to inspect the saphenofemoral junction, but I don't actually like to do this during this nowadays because of the COVID. So you have to ask a patient to cough, and then you feel thrill here. And whenever you feel thrill here, this means that the saphenofemoral junction is affected. There is a reflux in the deep system. And why we feel thrill here? Because we have a saphenofemoral junction incompetent, and we have all the way from the chest, abdomen, and to this part is valveless, as we have seen before in the anatomy. So because we can feel thrill here if the valve is destroyed, because we don't have any valve in the abdominal part of the blood vessels. And also we have some tapping test. What is tapping test? I press over the vein by the upper in the upper part of the vein, and I feel tapping downward. In the normal scenario, when I compress or tap the vein by proximally, I cannot feel a distal pulse of my hand. Why? Because there are multiple valves in this area in between. Whenever I press here and then I feel the tap here or feel some fluids moving under my fingers, this means that this part is incompetent. I have a reflux in this area, and hence varicose. We have what is called a tourniquet test. We elevate the leg of the patient. We elevate the patient leg and then apply a tourniquet in the saphenofemoral junction, and I ask the patient to stand. Whenever I see veins refill after being empty, this means that there is some perforator here that result in incompetent perforator here that fills the patient back with the blood. Actually, all these tests are replaced nowadays by the duplex ultrasound, so we don't stress on this test so much. You have to know a superficial or an idea about this test, but not in details, because it is completely replaced by the duplex. What is duplex? It is a machine that can find or detect everything you need to know about varicose vein. It will tell you whether there is a reflux or occlusion, whether there is a thrombosis in the deep system, for example, which part of the veins is affected, a superficial vein or a deep vein perforator is affected or not. Duplex is very good, it is very sensitive, and it is non-invasive. This is for just for fun, and we have an application for it, which is called ambulatory venous pressure. As you know, we can differentiate between primary and secondary varicose vein by the history of the patient. Whenever you ask the patient who have a primary varicose vein, do you have pain during walking? The patient will tell you that during walking I feel pain or heaviness in my leg while during standing. But when I walk, the pain relief. Why is the pain relief? Because whenever I have muscular exercise, the muscle pump more blood, although there is the flux of the blood, but the muscle acting as a pump, and so the venous return of the lower limb will be improved even in case of varicose vein. So whenever I have a venous pressure in my leg, whenever I start to walk, the venous pressure will decrease. But on contrary, when the patient has a deep system affection, when the patient walks, he will feel pain, and the pain will increase, and the patient will tell you that I feel my leg is going to be burst, or it is very heavy. Why? Because the deep system affecting my leg, and hence the pressure inside the deep system is increased. So ambulatory venous pressure is not done for the patient, but I put this slide for you to know why the patient during walking in primary varicose vein improves, his symptoms improve, because venous return will increase and the pressure in the superficial system will decrease. And the patient with deep system are not good, because the deep system is occluded and the pressure will increase in the deep system. We may do some investigations with is called venogram. We may, it is not in every case, we may inject some veins by dye, and hence we can see this collateral which is going from right to left. This means that in this patient, the patient has a problem in his right iliac vein, so the dye does not go directly upward through the inferior vena cava, but the dye is going to have cross or doing some sort of bypass to the other side to be drained in the left side. This patient has a previous DVT which occlude or affect the right iliac vein. We have we may do some sort of CT venogram, and we can find what is called triple Treonine syndrome. Triple Treonine syndrome is a syndrome in which the patient suffers from some sort of affection in the left lower limb. The iliac vein is compressed by the left iliac vein is compressed by the right iliac artery. It is a rare syndrome, sometimes present and resulting in venous manifestation in the left lower limb. It is not important to mention it, or you have to mention if you mention it, please let it the last part in the investigation. Whenever you are asked about the investigation for varicose vein, please say it is a duplex ultrasound, and then you can add ambulatory venous pressure or venogram or CT venogram, but don't start with CT venogram. What is the investigation for varicose vein? It is duplex ultrasound. And you can see in this venogram that the left iliac vein is crossed and compressed by the right iliac artery, and hence there is some sort of affection of the venous return, resulting in opening of the collateral in the suprapubic area to bypass to other side. Another patient with previous DVT, the DVT that affects the patient did not resolve completely, so the IVC is included, and the patient have a huge collaterals in the abdominal wall to bypass the occluded IVC, and here is the cause. And this appearance is well known for you as a caput medusa. Caput medusa, that means that we have a serpentine or multiple veins in the anterior abdominal wall. It occurs in case of occlusion of IVC. Occlusion of IVC could be due to the previous DVT or malignancy or retroperitoneal fibrosis that compress the IVC. Okay, venous system. We in the venous system we have mentioned that I have varicose vein, primary or secondary varicose vein, and I may have some complications. The complication of primary varicose vein is superficial thrombophlebitis. What is superficial thrombophlebitis? It is an acute condition. The superficial veins is included. The patient has a cord-like structure in the great saphenous vein. It is tender, hot. It seems like the patient has some sort of cellulitis. It is painful. It is dangerous if it is left, because it could expand and go to the deep system, resulting in deep venous thrombosis. It is superficial thrombophlebitis. The most important part in superficial thrombophlebitis, whenever you have what is called migratory thrombophlebitis. What is migratory thrombophlebitis? You will have a patient that gives you a history that I have superficial thrombophlebitis in my right lower limb, and then I have one in the upper limb affecting, for example, cephalic artery. Then the left lower limb has something like this, and the return again. Whenever you have this migratory thrombophlebitis, you have to think about having internal malignancy, which could be any malignancy in the GIT, especially in the pancreas. So superficial thrombophlebitis is not a serious condition, but when it is migratory, that's to say it is a recurrent, you have to think about internal malignancy and search for. Other complication of varicose vein is bleeding, which is very, very, very serious. The bleeding from varicose vein is profuse, as you say. As you can see, it is painless, and the patient, if it affects old patient that may live alone, they may die smoothly without any notice, because the patient may bleed during night and he does not feel any pain. He may bleed to death. It is very important to know how to treat this bleeding varicose vein just by compression. Please don't try to stitch it, because if you stitch this part, it will result in an ulcer. So whenever you have a varicose vein, you have to compress it. The pressure, you don't need high pressure, because the pressure in the veins is not very high. So some compression, you may apply crepe bandage, and then you may do some injection cryotherapy. This means that you inject some sclerosing area in the surrounding veins to occlude these veins from bleeding. We may have other pathology or other complication for the patient in long-standing venous insufficiency. That's to say, in long-standing primary varicose vein or in a secondary varicose vein, I have a deep venous pressure. Deep venous pressure resulting in edema, as we have said before, and due to this edema, the component of the blood will escape from the blood to outside. The part will escape could be fibrinogen, resulting in fibrosis of the subcutaneous area. RBCs could escape and destroy and rupture, resulting from escape of hemosiderin from the blood, resulting in black discoloration of the skin and pigmentation. This is a complication of either primary varicose vein or secondary varicose vein. But a primary varicose vein, to reach this complication, we see is lipodermatosclerosis, and this white spot is a previous healed ulcer. Needs years and years. Why? Because in primary varicose veins, the pressure in the superficial system is not that high to cause these changes, so it needs years to do so. But in case of secondary varicose veins, the deep system is affected and the pressure in the deep system is high, so the development of these symptoms will be higher than primary one. Another form of post-thrombotic syndrome, this resulted from primary varicose or secondary, but most of the cases it is due to secondary varicose. As you see, the patient leg is called inverted champagne bottle. It is like a bottle with the neck inverted to the downward to the foot. Why we have an inverted champagne bottle? Because I have some sort of venous occlusion, so there is edema of the lower limb, and at this area there is a fibrosis or lipodermatosclerosis that results from escape of fibrinogen from blood, causing cuff or tourniquet effect or crepe bandage around the lower part. So the increased pressure will result in edema, but this edema cannot yield this fibrosis in the lower limb, so the patient will suffer from proximal edema and distal stenosis. It is called inverted champagne bottle. This is an ulcer, and if we revise the C classification, it is C6. Why? Because we have active ulcer. Is it a venous or arterial ulcer? Yes, definitely it is a venous one. Why it is a venous one? Because the surrounding area of the skin looks not good. It is looks congested, and the lower limb is edematous. This means that we have some venous problem. And if you feel the pulse, anterior tibial or dorsalis pedis pulse, posterior tibial pulse, you will feel pulsation. So you exclude arterial edema. In most of the cases, we said that the venous ulcer present in this area. What is this area? This area is the lower third of the leg in the medial aspect. And when I ask you why it is present in this area, which is called the gator area, You have to mention that it is the most dependent area in the lower limb, so it has a high pressure. This is number one. Number two, I have a lot of perforators in this area, which is called Cock's perforator. This perforator will apply or will carry the deep pressure in the deep system to the superficial one. So why ulcer present in the gator area? The ulcer is present in the gator area because of being dependent, and there is a lot of perforator here. But this does not exclude ulcers from affecting other area. Here is a patient, for example, have a post-thrombotic syndrome with an ulcer in the outer surface of the leg. It is on contrary not on the gator area. Why it is a venous ulcer? Because I have a lipodermatosclerosis surrounding the patient, and the patient has an edema for lower limb, and most probably it is a venous one. How I can treat patient with chronic venous insufficiency? Chronic venous insufficiency means primary varicose vein or secondary varicose vein. The first thing that you have to know that if you want to treat varicose vein, you have to treat the pathology. What is the pathology? The pathology is increasing in the venous pressure. So if I have an increase in the venous pressure, I have to treat this. How? Number one, by compression therapy. And please, if you say compression therapy or compression garment or compression stocking, don't say compression only. It is not a compression. It is a graduated compression. What is mean by graduated compression? This means that it is not a crepe bandage. So if you ask a patient to apply a crepe bandage, this is wrong. He has to wear a graduated compression garment. Why? Because I don't need compression, but I need a graduated compression to restore the hemodynamic of the venous system. So I need a stocking with distal compression, high compression that decrease gradually. So when the patient wear this elastic stocking, it will help venous return of the lower limb. Sometimes when the patient have an active ulcer, we use this leg elevation to elevate pressure and allow for the healing of the ulcer by decreasing pressure. Sometimes the complaint of the patient is cosmetic, so the patient is anxious about having this arborization or this veins, so we are doing some sclerotherapy. Sclerotherapy is not here, the superficial sclerotherapy is not done for treatment, but it is done for cosmesis of the patient. And sometimes we do some what is called foam sclerotherapy, and as you see in certain in certain situations that it is called الحقن المتصلب أو الحقن الغروي. This means that you are transforming the injecting fluid into a solid one. How? By mixing with air. This is the connection, and you apply some air to this fluid, and so you are doing as if you are doing bubbles with soap. So this clear fluid, if it is shaked with air, it will cause bubbles and resulting in something like cappuccino foam. The value of this cappuccino foam or the foam is that you increase the volume of the injecting material, and you can see this foam is stable. That's to say, whenever you inject this foam, it will not escape to the deep system and will not do harm. This foam therapy could be injected through a catheter in the superficial system under guidance by ultrasound. You can see the vein by the duplex, and then you can inject your material under vision by ultrasound. This is what we have said. This is the probe of the ultrasound. I can see the vein here, then I apply my syringe with foam and inject here. When I doing foam sclerotherapy, I'm not afraid of escaping of some of the sclerosing material in the deep system, because the foam is heavy, not heavy, it is stable. So whenever I inject here, it will remain here and not escape. And after injection, we do some compression for the veins in order to occlude the vein for a cosmetic reason. The gold standard for treatment of varicose vein is surgery. We do some inguinal incision, and we here expose the saphenofemoral junction. Then we separate the vein and then apply what is called a stripper, which is a bar of metal that, or a bar of plastic or metal. Apply it from downward, and I apply it until upward. Sometimes some people ask, do you apply stripper from downward upward or from upward downward? The answer is from downward upward. Why? Because when I apply the stripper from upward, I may find some competent valve that prevents the stripper from going downward. So I apply the stripper from downward upward, and then I receive the stripper here. I tie a suture around the vein, and then I pull the stripper with the vein. You have to find, it is very important that before doing this, you have to cut these tributaries, the superficial circumflex iliac vein, superficial epigastric vein, and superficial external pudendal vein before removing the vein, because if you let these veins present, this will cause recurrence of the veins, and after you pull up or pull out the vein, the great saphenous or short saphenous will come out within the stripper as it is seen here. Sometimes we do ligation of perforator through endoscope. The patient, as you see here, have lipodermatosclerosis, and if you and we have some incompetent perforator here. If you if you do surgical incision here, you will open in a very bad skin, and the skin will not heal, and resulting in ulcer. So it is very talented to go in a healthy area with an endoscope till you find the perforator. This is the perforator that affects the skin, and then you can ligate, clip, or burn this perforator. So you are doing a minimally invasive surgery, following you are doing what is called remote surgery. You need to do surgery here, but you cannot go there from here. So you are going a little bit upward in a healthy area, then you can do your surgery. Some people think about why you have to do surgery and remove great saphenous vein. You can destroy the great saphenous vein while it is in place. This is through what is called radiofrequency or laser. This is the vein. I insert a catheter, and this is the probe of laser or radiofrequency. The idea is very simple. This catheter will give some heat. The heat will burn the great saphenous vein or lesser saphenous vein, and then the vein will be occluded inside. It means it is like that you remove the vein. Actually, the endovenous ablation, the recurrence rate is high, because sometimes the vein, after being cauterized by temperature, it may recanalize again, and the patient have recurrence of varicose vein. But the value of it is a minimally invasive one, and the patient can return to work very early. Clarivein is another treatment, and you have to forget about it. It is something that inject sclerosing material in the vein to occlude it. It is not important for you. This is varicose vein. Do you have any questions about varicose vein before going to second session, or we can continue?
Everything is clear, Dr. Hassan. I think my only comment is you are very clever in insisting and explaining the important thing to them, and not ignore, just to pass on the little things which they are not concerning with.
Okay. So on the other hand, we are excuse me. On the other hand, we as if you remember the first slide, it was about venous system. We have a dilated venous system, which is varicose vein or post-phlebitic, and we have, on contrary, the second part, which is a DVT. What is DVT? DVT is thrombosis of the blood vessel of the vein. What veins are thrombosed or occluded? It is a deep vein. The deep vein could be a deep vein in the lower limb and could be a deep vein in the upper limb. So I have a DVT in the upper limb, I have a DVT in the lower limb. If it is in the upper limb, it affects the axillary or subclavian vein. This occurring patient who needs a central venous catheter or a pacemaker or some catheter for dialysis for those who have renal failure. And other or the most commonly thrombosis is in the lower limb. This Deutsch or German scientist, it is called Virchow. It is very famous in pathology and in medicine. Virchow stated that whenever you have something that causes hypercoagulable state or doing injury for endothelium or have some sort of stasis in the circulation, the patient will suffer from a DVT. What causes this? The patient will have a hypercoagulable state if he has a malignancy, if the patient the woman is pregnant, if she has contraceptive pills that contain estrogen, or sepsis, or some congenital form of what is called thrombophilia. Thrombophilia means that the patient have some anomalies in the coagulation cascade that result in tendency for thrombosis. Also, we may have some endothelial injury, as we have said before. If you put a catheter in the vein, or you do some surgery, or the patient is affected to the trauma to the nearby vein. Sometimes patient drug addicts that inject themselves in the femoral vein or the saphenous vein, they are doing repeated trauma by the needling and by the drug. They cause trauma to the veins. Venous valvular damage, sometimes varicose vein, but it is not very common. Varicose vein may do some sort of endothelial injury and it may resulting in DVT, but it is not very common. So don't be afraid whenever you see a patient or whenever you have a varicose vein. It is not doing DVT in most of the cases, but it could do. And some circulatory stasis, that is very important when you ask patient about previous DVT. We have to ask the patient whether you are immobilized for a long period of time. The patient may have chronic illness that resulting in bed rest. The patient may have a fracture of one of his bone and resulting in fixation in plaster of Paris and hence circulatory stasis. If you have hypercoagulable state, endothelial injury, or circulatory stasis, then you will fulfill one of the Virchow triad. You don't have to have three, one of them. One of them is enough to do DVT of the patient. What is DVT? DVT means that the venous system is occluded by thrombus, and the dangerous of this thrombus is its sequelae. At first, the patient will suffer from edema of the lower limb, some heaviness, swelling of the lower limb, and the problem, the problem is the complication, because part of this thrombus could detach and will go to the heart. Nothing will be done. Then the heart will pump it to the lung. Whenever the thrombus is pumped in the lung acts as a filter, and the pulmonary arteries will be blocked or plugged by this impulse and resulting in what's called pulmonary embolism. So the patient will have an occluded pulmonary artery, so the patient can inhale and exhale, but gases exchange will not happen, and the patient will draw or suffocate although he is breathing. So it is very important. The nightmare of deep venous thrombosis is the development of pulmonary embolism. If the patient survives and no pulmonary embolism or no impulse occurs and the DVT is resolved, as you see, the valve will be destroyed and the patient will suffer from post-phlebitic syndrome, and hence the deep system pressure will increase, resulting in reflection in the superficial system and resulting in a secondary varicose vein with its sequelae as a post-phlebitic and venous ulcer. This is DVT. The patient has a swollen limb. Sometimes the leg is congested. There is a swollen limb compared to other leg, and if you palpate or examine the affected part, here is the calf muscle. If you examine the calf muscle, you will find the calf muscle is tense. We said it is turgid. Turgid, it means it is heavier than normal because there is a lot of thrombus here present in the lower limb. So we think patient have a DVT. It's going to, it is. We don't need to say you have a history of one of the Virchow triad. You have a history of hypercoagulable states. It is very important. The patient may be a pregnant patient or going post-surgical condition. Not every patient have a swollen calf, have a DVT, because the patient may have a calf muscle tear. If the patient have a calf muscle tear, you will find the same as DVT, because the muscle will be dense, tender, turgid, edematous, painful. It is very, 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 very important and crucial not to start anticoagulation before differentiating calf muscle tear from DVT, because if you give the patient, if you think your patient has a DVT and he wasn't, and have a calf muscle tear, and you start anticoagulation, you will end by this disaster. The hematoma, which results from tear of the muscle, will increase, and the patient will have this when you have a calf muscle tear, you have to apply cold fomentation, some rest, some lead elevation, and some compression. And it goes without saying, you don't need any anticoagulation. How you can differentiate between both? You can differentiate between both on clinical history. The patient gives you a history of long recurrency or plaster of Paris for previous fracture, or contraceptive pills if the patient, if your female patient uses some of them. And if you palpate the patient, you will find that whenever you palpate the calf muscle in a posterior-anterior direction, the patient will feel pain more than compressing the muscle from side to side. If in this leg I compress posterior-anterior, I compress the sinusoids in the soleal muscle, so the patient will suffer from pain due to direct palpation of the sinusoid. But if I compress from side to side means that I compress the muscle. So when I compress the muscle, there is a little sinusoids inside the gastrocnemius muscle, so the patient pain will not so hard. So in DVT, posterior-anterior compression gives more pain than side to side. In calf muscle tear, side to side is more painful than posterior-anterior. Why? Because when I compress the muscle side to side, I do compression about the gastrocnemius or soleus, and the patient will experience pain from side to side more than posterior-anterior. Also, the patient with calf muscle tear will give you a history of some trauma to the calf muscle. The trauma could be very retrieval. The trauma could be just getting off the pavement, or he sometimes give you the sensation that he feels something pop out in his calf muscle, and whenever the patient tells you that, you have to think about some sort of muscle tear. Also, at the end, duplex ultrasound could differentiate between both. Patient may have cellulitis. It is similar, or it may give a history, or it may give an impression of DVT. But during cellulitis, the patient will be feverish. You may see some oozing of fluid, some pus, leg elevated, increased temperature, or the patient is feverish, ill look. If you do CBC, you will find some leukocytosis, and it is easily to be differentiated. Although from the first look, it looks like a patient with DVT. How you can treat patient with DVT? It is simple. You have to let the patient rest, leg elevation, and encourage the patient not to do massage for his lower limb, because you don't want to move any thrombus or fracture any thrombus, and hence prevent pulmonary embolism. You can give patient heparin, anticoagulation, antivitamin K, whatever. But I have to say that in some during this treatment by anticoagulant, the thrombus will remain, and we leave the thrombus for the body to resolve it. But if you diagnose the DVT early, you could do some sort of thrombolysis. What is thrombolysis? You apply streptokinase or urokinase or tissue plasminogen activator through a catheter in the occluded vein, and hence you can reopen the vein after lysis. This is the vein. It is occluded, and only a small part of the vein is still patent. And after overnight thrombolysis, the vein return to normal. But to do thrombolysis, the patient must be diagnosed very early, because after a few days, the thrombus will be organized and the thrombolysis will do nothing. Another patient with a thrombus, here the vein is good, and this part is occluded by a thrombus. When you apply thrombolysis through a catheter overnight, then there is a complete lysis of the thrombus. By this we finish the venous system, and we are going to discuss one of the topics of the arterial system, which is an aneurysm. Any question about the venous system? Okay. Yes.
There is a question in the chat box. Hala Hassan asking why in primary varicose vein the varicosities begin proximally and proceed distally.
Actually, the varicosities is
reverse. Actually, it's reverse.
No, it is okay, but actually sometimes varicoses start from distal to proximal. But in most of the cases, or we teach students that it starts from proximal to distal.
She's asked why. What's the reason?
Because the problem at first is the saphenofemoral junction. In most of the cases, sometimes it is reversed, but in most of the cases, the problem is the saphenofemoral junction. Whenever I have an incontinent saphenofemoral junction, the pressure in the deep system will be the superficial system will be exposed to the pressure in the deep system. So the pressure will increase in the superficial system, resulting in dilatation of the superficial system. The proximal part of great saphenous will be dilated. Whenever it dilates, the cusp of the next valve or the distal valve will not be coapted together. And there is dilatation of and the separation of the cusps away from each other. So the second valve will be incompetent, and hence the third valve, and so on. So it seems it is like whenever you inflate a balloon, for example, a long balloon, the proximal part will be inflated, then the pressure will be reflected to the most distal one.
So usually it is the proximal one which is affected because the main cause is the incompetent severe.
Yes.
Thank you.
But in some cases, it starts.
The reverse come.
Yes. But for our student, it is starting from proximal to distal.
And the cause is because most of the varicose vein is because of the incompetent saphenofemoral junction.
Yes.
Thank you.
Okay.
You can proceed, sir.
Yes. Pulsatile swelling. It is the introductory part for aneurysm. Whenever you see a swelling which is pulsating, you have to think that you may have a normal blood vessel, but it is kinked. You have an extra length of the blood vessel, so it is kinked, so bulge from skin and appears as if you have a pulsatile swelling. This is one of them. You may have a tumor, just as a cancer thyroid, for example, or a very vascular tumor that may appear pulsating. You may have a mass which it could be above or below the blood vessel, and so you can feel the pulse. But due to in our main interest, the pulsatile swelling could be an aneurysm. What is aneurysm? It is very important to stress on definition. It is important. Aneurysm is a localized or focal expansion of the artery, more than 50% of its diameter. That's to say, whenever I have an artery which is expected to be 1 centimeter, for example, in caliper, and I have part of it or localized or a focal part, which is 1.5 centimeter, then I can apply definition of aneurysm. But I have what is called arteriomegaly. What is arteriomegaly? It is the same as aneurysm. I have a 50% increase in diameter of the artery, but it is not a localized, it is a diffuse one. So I have all the arterial system, for example, are dilated. I'm not afraid about arteriomegaly. Why? Because the whole system is dilated, so I don't have any turbulence of flow or thrombus formation. And I have sometimes ectasia. It is very common with old age. The patient is an old age, the blood vessel is exhausted over time, so there is a diffuse dilatation of the artery. It is like arteriomegaly, but it is less than arteriomegaly because the arterial system is less than 50%. Our job is to treat aneurysm. Why? Because it is localized, so I can treat this part, and because of being localized, it has some hemodynamic changes that affect the general health of the patient. But arteriomegaly and ectasia is not treatable. I cannot treat the whole arterial system. So arteriomegaly and ectasia, we just assure the patient that he has nothing and he can go without treatment. I stress for the last time, whenever you are asked about aneurysm, you have to say it is a localized permanent dilatation. It is very important to mention this localized part. Aneurysm could be a false one. What is meant by false one? This is the artery, and the artery is dilated. It is a true one. Why it is true? Because all the artery is dilated. But sometimes I may have a puncture in the wall of the artery, during this, due to this puncture, there is a surrounding hematoma around the artery, and the hematoma will be confined by the surrounding tissue. For example, the surrounding fascia, muscle, skin, and whatever. So at the end, I see a swelling which is pulsating from outside. I cannot differentiate between them, so I will diagnose them as aneurysm. But when I do some history taking or some investigation, I can get from the patient in this patient that he has a previous injury. He may have an iatrogenic injury by, for example, angiogram, for example, or coronary stent or something like this, that result in trauma of the artery and hence the aneurysmal dilatation. It is called pseudoaneurysm because the artery is normal. As you see, the artery is normal. There is no dilatation of the wall of the artery, but there is an associated hematoma which is communicating with the artery, so giving the false impression that there is a dilatation of the artery. So this artery has an aneurysmal dilatation, is a true one, and this artery is completely normal except for the defect that is connected to the hematoma, so it is a false aneurysm. There is some example of false aneurysm. This child has some problem with a broken glass, and he has an aneurysm in the radial artery. This lady is a drug addict and has some injection and resulting in a pseudoaneurysm due to multiple injections. Another patient with aneurysm resulting from a stab in the one of the branches of the profunda. This is a profunda artery, and this is superficial femoral artery. As you see, one of the branches having a leak, and this is the aneurysm of the patient. Also during arteriovenous fistula, for dialysis, sometimes there is some problem and resulting in aneurysm. This is aneurysm of the brachial artery. The brachial artery is normal, but it is a hematoma surrounded by capsule formation. Another one with popliteal artery, and I don't know whether it is a stab or something like this, but I don't remember the case exactly. But the popliteal artery have a defect, and this is a pseudoaneurysm of the artery. Why it is pseudo? Because the popliteal artery is a supragenicular part, and the infragenicular part is completely normal, just a small rent with dilatation of the artery. This is a very famous case done. The patient have some sort of fixation of the dorsal spine, and during fixation of his dorsal spine by one of the nail, this touched the thoracic, descending thoracic aorta, and the patient have pseudoaneurysm of the aorta. This is the aorta. The aorta is completely normal, and there is a defect from this nail resulting in pseudoaneurysm. Another classification for the aneurysm, according to the location, we may have aneurysm in the cerebral part, in the abdominal aorta, in the femoral, in the gluteal, and so on. It is just an anatomical classification. And we have a morphological classification. Sometimes I have a full dilatation of the artery called a fusiform aneurysm, or I may have a saccular aneurysm. And you have to differentiate between saccular aneurysm and pseudoaneurysm. Saccular aneurysm, it is a true aneurysm. We have weakness of the wall of the artery, and all the width is dilated. But in pseudoaneurysm, this dilated part is just a hematoma covered by fibrous tissue. But in this saccular aneurysm, it is the dilatation, and the wall is the wall of the artery, so it is composed of intima, media, and adventitia. Why we insist on the morphology of the aneurysm? Because every aneurysm, the shape of the aneurysm will affect the method of treatment of the aneurysm. We will see it later. What is the cause of the aneurysm? We don't know actually what's the cause of the aneurysm, but atherosclerosis is accused for most of the aneurysm, because atherosclerosis will occlude the vasa vasorum that supplies the blood vessels, and resulting in weakness of the wall of the blood vessel, and hence its dilatation. It could be a congenital due weakness of the arterial wall, and this is very common in cerebral aneurysm. Suture line aneurysm, you can do bypass, for example, for the patient, or insertion of a graft, and at the site of suture you may have aneurysmal dilatation. It could be trauma, as in this patient, and we may have what is called abnormal artery aneurysm. It is not needed by the student in this undergraduate to know abnormal artery aneurysm, but it is a nice part to know, just to have an idea about it and then forget it about it. This artery is not normal, as you see, because the normal artery is passing in this situation. The femoral artery is here. It is divided into profunda artery and superficial femoral artery, and the superficial femoral artery will continue to give a profunda artery, a popliteal artery. But during embryogenesis, there is what is called sciatic artery. Sciatic artery is an artery which will go within the sciatic nerve, and the sciatic artery late in the embryonic life will occlude and will be substituted by the femoral artery. In some cases, the sciatic artery will persist. It is an abnormal artery. When it persists, the superficial femoral artery will not develop, and the patient will depend on the sciatic artery to supply his lower limb. And because sciatic artery is present in abnormal situation, it passes around the ischial spine and the tuberosity. So the patient during sitting, there will be repeated trauma to the artery, and hence the artery will be dilated and causing an aneurysm. You are not asked about the abnormal artery aneurysm, but if you know it, it will be good. Also, another classification of the aneurysm, which is according to pathophysiology. Sometimes we have a mycotic aneurysm. What is mycotic aneurysm? As the name indicates, it is aneurysm due to fungus infection, but actually this name is misleading. They thought that sometimes we have infection in the artery resulting from fungus infection, resulting in aneurysm. But later on, it is not due to fungus infection. Sometimes I have infection in the artery causing dilatation. It is infection by bacteria and not by fungus, but it still carries its name, which is called mycotic aneurysm. There is a syphilitic aneurysm, which is not anymore present, and the degenerative aneurysm in patient with some connective tissue disorder as Marfan syndrome, or Ehlers-Danlos syndrome, or Loeys-Dietz syndrome. In this patient, there is a connective tissue disorder. So as you can see, there is hyperlaxia of the blood vessels, and there is a problem in the connective tissue collagen number 3 and 6, resulting in weakness of the connective tissue, and hence weakness of the connective tissue of the artery and dilatation of the artery. How we can treat aneurysm? Treatment of the aneurysm, as we have mentioned, what is aneurysm? It is a localized dilatation of the artery. So because of it is localized, I can treat it. Repair of the aneurysm, I can excise the part because it is localized. I excise the part of the artery. This is the artery which is dilated with the aneurysm. I localize this part and replace it by a synthetic material. So the patient, so I removed the weak part of the aneurysm and replaced it by a graft. Sometimes the artery is not important, as radial artery, ulnar artery, perineal artery. So if the patient can withstand occlusion of the artery, so simply I will not do this bypass and I occlude the artery to exclude the aneurysm. This is what I have said before. The type of the artery will help the treatment of the patient. This artery is a saccular. This aneurysm is a saccular aneurysm, so I can do a side clipping for the aneurysm to occlude it, and can by endovascular put some coils inside the aneurysm to exclude it and induce thrombosis and hence fibrosis of the aneurysm. This is more common in the cerebral aneurysm than in the peripheral one. The important aneurysm for us as a vascular surgeon is the abdominal aortic aneurysm. The normal aortic caliper is maximum is 2.2, but the average is 1.6 to 2.2. 2.2 is in giant persons, as in basketball player, for example. We have multiple types of abdominal aortic aneurysm according to the relation of the renal vessel. Sometimes aneurysm affecting aorta below renal vessel, sometimes flush with the renal vessel, which is called just the extrarenal, sometimes extend above the renal vessel, and sometimes affecting the thoracic part and the abdominal part. This is a simplest form, and this is the most complicated form. This is arteriogram showing renal artery and the aneurysm, the dilated part, the juxtarenal. Infrarenal aorta is the most common. Fortunately, it is the most common because it is it has a good prognosis. Whenever you see a patient with femoral artery aneurysm, but when we say femoral artery aneurysm, we say true femoral artery, not a pseudo femoral artery. You have to think about concomitant AAA, which is abdominal aortic aneurysm. So if I have a femoral artery aneurysm, in 80% or 85%, I have a chance to have a concomitant AAA. When I have a patient with popliteal artery aneurysm, 60% I have a chance to have an AAA. If you have a patient with hypertension, he's a cigarette smoker, about 60 years old, then you have to think about having an abdominal aortic aneurysm. And as you see that the aorta is very upset because it reaches 5.5. Whenever you have your aneurysm reaching 5.5, it is an indication that you have to start with treatment. The presentation of the aneurysm could be asymptomatic, could be a space-occupying lesion just for early satiety and feeling of fullness, or may have some compression of the surrounding as a back pain or compression of the vena cava causing lower limb edema, or we may have what is called Pluto syndrome. What is Pluto syndrome? The aneurysm is dilated, there is turbulence of blood and formation of thrombus inside the aneurysm, so part of the thrombus will detach and causing distal embolization, and the patient may suffer from what is called Pluto syndrome. Very dangerous complication is whenever you have a ruptured aneurysm. If you have a ruptured aneurysm, the patient will have a triad of hypotension and shock, abdominal pain due to escape of large amount of blood to the abdomen, and the patient will change into a pulsatile abdominal mass. If the patient, if the rupture occurs intraperitoneally, the patient will die, and you cannot save the patient because the patient will lose all of his blood through 2 or 3 minutes. So a patient have an intra-abdominal or free rupture in the abdominal cavity will die. So no way that you can help him. But fortunately, the scenario is not like this. Sometimes we have a leaking rupture, what is called leaking rupture. The rupture will not be in the anterior part or not in the abdominal part, but it will result from some erosion or some defect in the wall of the aneurysm in the posterior part. So the bleeding will be in the retroperitoneal area. Retroperitoneal area is a confined space, so hematoma will compress this rent and helps and help to give you sometimes to save your patient. These photos representing patient with rupture aneurysm. As you see, the abdomen is full of blood, and this will be reflected to the bluish or bruises in the anterior abdominal wall. It is like that with hemorrhagic pancreatitis or rupture, disturbed ectopic pregnancy, or any intra-abdominal hemorrhage. This is also a lion ecchymosis due to leaking of the aneurysm or of aorta or iliac vessels. And according to Laplace law, whenever you have a balloon or aneurysm or a sac, whenever you increase the diameter of this sac, the tension of the wall is increased. So it is very important to consider treatment of the patient when the diameter of the aneurysm reaches 5.5, because above 5.5 the risk of being ruptured is very, very high. And the differential diagnosis of the rupture aneurysm is the same as differential diagnosis of acute abdomen, starting from perforating gastric up to lymphoma, ruptured nephrotic hepatobiliary cancer, whatever. It is like the differential diagnosis of acute abdomen, because the patient suffers from acute abdomen and hypotension and all go with these manifestations. To investigate a case of abdominal aneurysm, I said plain film. Please don't say plain film at the start. I just put this X-ray to see the shell or calcification of the wall of the aneurysm. You can see this calcification. But if you say the first investigation to investigate an abdominal aneurysm is a plain X-ray, you will have a very bad mark. So at the end of your investigation, you can say, I can have a plain film that shows some calcification of the aorta. Please don't put it at the first choice of your diagnosis. I can use ultrasound, which shows expansile mass in the abdomen, retroperitoneal, and we can measure the abdominal aneurysm by it. We can do CT, and this is CT examination. This white part is the lumen of the aneurysm, and all this is the aneurysm. You say it is a huge aneurysm. You see this white part is the calcification of the aneurysm, and this is only the lumen. So if you do arteriogram for the patient, you may see this lumen only, and you think that you don't have an aneurysm. So the best in evaluating aneurysm is CT. When I do CT, I have to measure the diameter of the aneurysm. I have two diameters. If this diameter could be 5 centimeters, for example, but this is 7 centimeters. Which one will I consider? The largest one. So if I have this one, one plane, for example, 4 centimeters, and the other 7 centimeters, I will take 7 centimeters and say the patient needs intervention. Sometimes I'll do MRA. It is more preferred in the cerebral aneurysm if you suspect aneurysm in the cerebral region, and you can see you can do fine cut CT, that you see in our department during your round. And here you can see the 3D construction of the aneurysm, and you can see the angle of the aneurysm, the wall of the aneurysm, relation with renal vessel, and the condition of or patency of the vein. How I can treat this patient? If the patient have an aneurysm less than 5 centimeters and the aneurysm is asymptomatic, then do nothing for the patient, and please follow the patient every 1 year. If you have an increase in the girth of the aneurysm more than 1 centimeter per year, even if it is less than 5.5 centimeters, you have to interfere. That's to say, if I have a patient with an aneurysm 3 centimeter, and then after 1 year I did it and find it is 4.5. Still, it is below 5.5, but it increased more than 10 millimeter per year. It is an indication for intervention. If I have an aneurysm above 5.5, the risk of rupture is very high, and I have to repair the patient. And if I have an aneurysm which is complicated by pain or complicated by leakage, I have to do surgery for it, whatever the size of the aneurysm. If I have an aneurysm which is 3 centimeter and the patient suffers from pain, this means that it is an early signs of leakage or rupture, so I have to proceed for treatment. How I can treat the patient? I can treat it by surgical treatment or endovascular treatment. By surgical treatment, you open the aneurysm. It is like a mantle. You open the aneurysm, you put your graft, and don't leave the graft inside the abdomen, not covered. So don't excise the wall of the aneurysm, because I use this wall of the aneurysm as a mantle and suture it together to bury the graft inside. This is called inlay aortic graft repair. Why inlay? Because I open the aneurysm, put my graft here, and then close the wall of the aneurysm over the graft. We have another intervention, which is endovascular repair, not suitable for every patient. I have to do a CT and examine the patient. There is some contraindication to do endovascular repair for the patient. I apply a covered stent, and the stent must be covered because it will exclude blood from going to the aneurysm, and the patient is treated by endovascular treatment. This is inlay that we have said before. You put the graft here and you include or resuture the wall of the graft around it. This is the abdominal aneurysm. Open and the graft inside. This is live from OR, and then the wall of the aneurysm is resutured around the graft. This is the endovascular procedure. Very simply, the technique of endovascular. I apply a syringe until I have blood coming out from the artery. Then I apply a wire, then remove my needle and keep the wire inside and put what is called sheath, or it is something like a large cannula. And through this sheath, I can apply stent or wire or whatever through the I have few slides left. This is femoral aneurysm. We have we have mentioned the femoral aneurysm previously, and we said if you have a femoral aneurysm, a true femoral aneurysm, you have to think about concomitant aortic aneurysm in 80% of the cases. Yes, it is true. The femoral aneurysm is, in most of the cases, it is a pseudo aneurysm. Why? Because every intervention is done through the femoral artery. I can do for occluded vessel in my limb through the femoral artery. I can do coronary stenting through the femoral artery. So femoral artery is exposed to iatrogenic injury and resulting in pseudo aneurysm. It is not common to have a true aneurysm, and whenever I find a true aneurysm, I have to think about concomitant. True aneurysm is associated with femoral aneurysm, and femoral artery aneurysm is classified into type. What I have to do for the patient, this is duplex ultrasound showing the aneurysm dilatation, and I have to treat it. This is aneurysm by arterial vein, and I can treat it with a synthetic material. Popliteal aneurysm is very dangerous. It is in most of the cases it is bilateral. Also, it may be associated with AAA. The dangers of the popliteal aneurysm, it is liable to thrombosis. So consider this gold rule. If you have a popliteal aneurysm, you have to repair it. Nothing is called conservative measures with popliteal aneurysm. Why? Because popliteal aneurysm is very prone to thrombosis, and popliteal aneurysm is considered to be an end artery. That is to say, if I have a popliteal aneurysm and it is occluded, the patient will lose his limb. So please, if you diagnose or find a popliteal aneurysm, you have to refer the patient for vascular surgeon to treat him. Nothing for the conservative. And how you can diagnose popliteal aneurysm? It is very simple. Whenever you feel a popliteal artery easily, it is a popliteal aneurysm, because you find in most of the cases difficulty to feel popliteal artery. Whenever you see popliteal artery with ease, this means that the artery is dilated and you have a problem with the popliteal artery. So refer the patient for duplex ultrasound, and please tell the doctor that I am suspecting popliteal aneurysm, and if your diagnosis is right, you have to treat him promptly. Popliteal aneurysm is treated also by excision or exclusion of the aneurysm and the bypass to the aneurysm. Lastly, we have what is called cercoid aneurysm. It is not an aneurysm, it is an arteriovenous fistula present in the scalp. It is a rare condition. It is a misname which is called aneurysm. As we have said, it is an arteriovenous malformation, very liable to recurrence. You see the patient has previous excision and it recurred again. It is not an aneurysm, but it is an arteriovenous fistula. It is very important to know that cercoid aneurysm, it is an arteriovenous fistula. It is a misname. Lastly, visceral aneurysm, it may affect the splenic, hepatic, or superior mesenteric artery. The most affected part is splenic in 6%, followed by hepatic. The importance of visceral aneurysm, it is silent, but during pregnancy it may rupture due to effect of hormones, and the patient may suffer from internal hemorrhage and may die. Thank you. Any questions, شباب؟
دكتور
ايوه
تمام دكتور حسن، بس ما فيش كويشنز حتى الان. اي حد طالب عايز يسال اتفضل.
دكتور
ايوه
البوبليتيال انيوريزم لما نيجي نعمله تريتمنت هنعمله بالاوبن سيرجري عادي والاندوفاسكولار ولا؟
معلش ممكن السؤال تاني؟
بوبليتيال انيوريزم
ايوه
هنيجي نعمل نفس التكنيك بتاعت الاوبن والاندوفاسكولار؟
السؤال ده كويس قوي. لا، هو طبعا مش التكنيك بتاع الاندوفاسكولار. البوبليتيال انيوريزم ده، البوبليتيال زي ما انتم عارفين ده في منه جزء سوبراجينيكولار يعني فوق الركبه وتحت الركبه. Popliteal artery is composed of two parts, supragenicular and infragenicular. Because of nature of the popliteal arteries that cross a joint, it is not preferred to do a stent, because whenever the patient flex and extend his knee joint, the stent may fracture and may result in thrombosis. In very, very, very selected cases, when the patient is very old, cannot withstand surgery, we can do popliteal artery stenting. But the first recommendation is surgical treatment. It is forbidden to put a stent across a joint, except in very, very few circumstances.